Hi, everybody. Welcome. For me, this evening is a great pleasure and an honor to interview one of the most known prosthodontists in the world, a person who was able to put together many prosthetic concepts and create a systematic approach to the functional and aesthetic rehabilitation. He's author of 2-volume series, Aesthetic Rehabilitation in Fixed Prosthodontics, translated in 11 languages. He ran a private practice limited to the prosthodontics in Pesaro. I have the honor to introduce you Mauro Fradeani. Thank you.
Hey.
Mauro.
Thank you. Thank you for inviting me to this discussion. I'll be proud to participate to this kind of meeting with you guys. I'm honored.
That's great.
Sure.
Moreover, as a special guest, we have also another prosthodontic from Italy that will also really well known worldwide, Giacomo Fabbri from Cattolica, Italy.
Hello, everyone. Thank you. It's a good pleasure for me too to be here. Thanks.
And last but not least, for sure, a person who have no need to have an introduction is Dr. Sasha Jovanovic from LA.
Hello, everybody. And also for me, it's a great pleasure to be here together with, first of all, my long-term friend and colleague, Dr. Mauro Fradeani. Mauro, thank you for your time. And of course, with my colleagues and friends, Francesco and Giacomo. I look forward to this 1-hour interview.
Okay, that's great. So, just because right now it's a really, how to say, a really modern approach in prosto is what is probably one of your best approach in prosto, so the minimal invasive prosthetic procedure. So I consider you like a father of this kind of approach. The first question, how you get this idea, how the first time it pop up in your mind to do something like this, so to modify the classical approach?
Because I was too tired to cut teeth for all my life. It was too much, I was really too much. Actually, the main reason why was, of course, because I would like to start to do a kind of innovative procedure that allow me to avoid to devitalize all teeth like I did in the past. It was really incredible that all the teeth were devitalized before starting to do pros, most of the time, especially in the peri-pros cases. That happened for many, many years. It was maybe something that was needed, especially in peri-pros cases, because we had not implants yet available in the market, in the early 80s especially. That was the reason why I've been working with the periodontists who were really very good on cut, roots, keeping the right roots in the final prosthetic work. Actually, I have done a lot of this kind of work over decades already, but the last 15 years, I could say, I would started to say that if I could, I would like to keep vitality of teeth, to be not aggressive at all, and to really have the chance to even avoid to do anesthesia. That is something that is really, I don't say not comfortable for patients, especially if you do big cases, you stay all day long with the patient, you do anesthesia, and they do anesthesia again, again. So that was a kind of inspiration. At a certain time, I said, if I still have some enamel available, why should I cut away the enamel that is the best solution to bond the restoration there? So that was the, the first step.
Yeah, but in the beginning, you didn't find any trouble just because we were so used to consider a certain thickness and using this kind of material that were available, so the PFM classically, to do something different and then consider that was not too risky, for example, to have so thin material.
Yeah, of course. Of course, I've started not with the big rehabilitation cases. I've started to, with a little maybe restorations. Maybe I still remember the first time I did the central incisor, I showed you guys already this case. That was like 2 pins, like parapost. It was seeing that through the transparency of the enamel, some really black black shadow behind. And we knew that it was like a parapost there. And actually, I removed the parapost. The tooth was so short. I decided to, to do like at that time an Empress material that was like 90, 91, so 30 years ago. And actually, I was saying to the patient, listen, that is something that I try to do it, but I'm not sure that it can be still in the mouth in a few years. When you say that to the patient don't remember what you say. And maybe the two years after, if you fail, they say, why you fail? As I answer, I told you that could be risky. That is quite classic. But if you never risk, you never know. You have to do yourself. You have to do some experience. And of course, it's quite smart to avoid to do big cases since the beginning. It's smart to start with maybe a single restoration, try to check over time if he's still in the mouth of the patient, if he works well, etc., etc.
But
then
right
you
now,
can go ahead and work with different kind of work.
If you consider right now the classical approach that we had in the past, and right now the minimal invasive prosthetic procedure, do you think that for the young guys can be something that it's easier to understand, easy to approach, or is something that it's more complicated?
No, I think that theoretically and as a concept, as philosophy, of course, is easier, is more logical, in my opinion. But technically speaking, and also clinically speaking, you should be very, very meticulous dentist. I couldn't say that is ready for everybody. I would say that you have to be very careful because technique is important really to follow all details and to really have the chance to finalize your work in every moment in a very delicate way. Let me give an example. When you try in restorations, in occlusion, it will be very dangerous. Right now, if you bond restoration, normally using kind of glass ceramic material like lithium disilicate, that is much more comfortable to use it than the previous one that it was Empress. With the Empress, you put the restoration in the mouth, and you say close delicately the mouth, you have some brittle ceramic breaking on the margins. Today, with the lithium disilicate, is different. Is of course much safer. And that's the reason why I'm still using this kind of material, because I believe that is a quite nice material to use in this kind of situation here. Okay.
With your book that are, I think for a year, they were the bestseller in dentistry for sure. You were able to describe and clarify all the steps of the aesthetic analysis. But if you have to choose right now between your idea, every single time you see a patient, the first time you have to analyze the patient, what is for you the first step? What is the first step?
Seems to be crazy, but the concept to be followed in such condition, I mean, starting your kind of idea of how to treat the patient, how to analyze, and having the chance to idealize your treatment plan, okay? To idealize your treatment plan, you should follow the simple rules that you have in the denture. Actually, as we said many times, of course. We should find as first step the incisal edge position, frontally and laterally. It means that you have to be sure that the incisal position is in the right position. And of course, together with that, the most convex area of this incisal edge curvature that is convex, that follow the lower lip line that is concave, should be the tooth exposed at rest. Tooth exposed at rest should be around 3 millimeters in young ladies, 2 millimeters in young men. But getting older, of course, you have decreased the visibility because you maybe have worn dentition a little bit, also because the tonicity of the soft tissue decrease. At this point, become invisible. And that is, I believe, the most important step also to show to the patient. Because when you try to lengthen the teeth of your patient, sometimes you have people that react saying, oh, I don't want to have this kind of long teeth, because they refer the long teeth in considering what is the length now. But now the length is maybe reduced a lot is like no more 11 millimeter, but maybe 7 millimeter long. At this point, you have to consider that they are really not happy to elongate so much the teeth. But one important step that convinced them to try to elongate the teeth as you requested, as you suggested them, is to really show with the mirror the rest position. So the tooth exposed at rest position. Normally, you have the situation that is not possible to see any teeth at all because the upper lip is covering the incisal edge of the upper teeth completely. So they don't show at all the incisal edge area at the rest position. Seems that the teeth are not there. So that is a way how to convince the patient to follow your recommendation. That's to elongate it. And of course, today, if you have to add length, to add volume, you can do the mock-up and showing as a preview to the patient how to do it, how it looks, how it will look.
Yeah, yeah. And then in this case, for example, yeah, you underlined that the first step for you is the position of the incisal edge. And then for sure, with the teeth proportion, we will know where we want to have our future free gingival margin. And this is for sure something that every single time we see your cases are so nice, so beautiful, because all the proportion of the teeth are respected. So probably most of the time in this kind of approach, also to maintain an ideal aesthetic, you need also the collaboration of a surgeon in the way to create the ideal future free gingival margin. So probably it's something that you include in your therapy. Probably it's something that you do.
Depending, yes, of course. The proportion of the teeth, the right proportion that normally is for a central incisor on the upper arch, 80%, I mean, the width should be the 80% of the length. It means if you have 11 millimeter long, like central incisor, should be 9 millimeter large. So actually at this point, to have with your eyes, the eyes of an observer, not just the eyes of the specialist, but also the lay people, should see that a proportion that we discussed right now, between 75% to 85%, is recognized as an ideal one. So that is very important, especially in one condition, when you have the high smile line. Of course, if you have low smile line, you can also have a very nice, healthy situation of the gingiva outline. But at the same time, if you have maybe some disparallelism between right and left, not identical, but you have a low smile line, you can talk to the patient and say, we can stay like that because you never show your smile, I mean, the complete smile line to your relatives, to your parents, etc., etc. So at this point, depending on the eye smile line of the patient, if the eye smile line is a must. If it's low smile line, you can decide if you want to do it or not. Because of course you have to consider that you have to do maybe an orthodontic treatment or a surgical treatment before finalizing your case. And of course, it's more expensive, is more pain for the patient. You have to wait more, to pay more, and to suffer more. So depending on this smile line of the patient.
Yeah, just a question. But even if it's a low smile line, this is just between us, has to say. Sometimes I'm bothered if I see that even if it's a low smile line, sometimes you have the trend of, I don't know, the teeth, the soft tissue that is not ideal. So sometimes if it's borderline, even if it's not completely visible, just because as well as professionals, that's clinicians, sometimes I want to enjoy the final picture of the restoration. So sometimes, I don't know if you are tempted as well, because sometimes I'm tempted to try to have really a nice restoration, something that is look like if it's, even if it's
the main reason is because you like to do it, not because it's needed. That's the point.
Yeah,
I do it, of course. I'm doing either because, of course, I like to have, this case can become perfect, the end, because I'm presenting the congresses and the courses like you. And that's the main reason why you do it. You play with yourself. You don't say that you cannot. You say that you need to do. You need to do. It's something that they must do. But actually, it's not true. Sometimes it's not like that. Actually, I believe that, of course, for us is normal, but to try to optimize the case with the gingiva outline. But again, I believe that in some cases, the patient has to consider to pay more, suffer, is more involved on the treatment for longer time, and wait more to finalize the case. So I believe that you have to consider all these factors.
Yeah, that's great. So right now, changing a little bit the topic. So in the minimal invasive prosthetic procedure, one of the key points is for sure for a full mouth rehabilitation to increase the vertical dimension. And just to have speak a little bit about this topic, how you calculate, for example, if you have a word addition, so upper, lower, where is your, I mean, how you evaluate how much you increase?
Okay, that's
Francesco.
very nice.
Yes.
Mauro, can I ask a question?
Yeah.
Sure.
Just to like bring in, as most people know, I was trained long time ago as a prosthodontist, so I of course really love the field of prosthodontics, but my main focus is surgery. And it's always interesting for me when you look at the expertise that you have and the experience that you have, is how, just from an, I don't want to go into the technical part of like dentistry now, just how do you choose a team? Because like, you know, you have very challenging patients, and of course you bring in your experience and your expertise in the field of prosthodontics, but of course you need also to have orthodontist, you need like a surgeon like myself, you need other team members. And how do you do that? Because I think for a lot of young dentists, they have also problems to just put together a team. So what is your success kind protocol of knowing who is the best for yourself and for your patient?
Yes, it's really, sorry, I want to complete the question because it's really interesting topic and interesting thing. And I think that is really correct. The same story also for the dental technician. Because of course we need doctors, specialists, but of course for the prosthodontist also the dental technician is essential.
Yeah, I agree.
What to say? I believe that is on the team approach is very important, of course, but I believe that still the prosthodontist has the main responsibility to detect the final right position of the teeth. So, and then the implantologist and the surgeons has to follow the prosthodontist suggestions. It means that before saying, or before deciding, I would like to remove the tooth and put an implant. That is very important, of course, question, and that's to be answered. But in the meantime, what I would like to have it, even though is a teeth that is kept in the mouth, or you put an implant, at the same time, you have the chance to, of course, idealize the position of the teeth. That's the first step that has to be done. And this first step has to be analyzed and decided by the dentist, by the prosthodontist, and then has to be transferred as information to the dental technician. So dental technician is very important to finalize the case and to understand the case together with you. But of course, all the indication and suggestion has to be sent by the dentist to dental technician. Technician cannot decide for you if they don't see the patient. Normally they don't see the patient.
In which way do you choose in which way you choose the surgeon that is working with you? It's probably almost the same, and also the technician. How you choose between your team?
In terms of surgeon, the less expensive. So I don't choose in the session that is very expensive. I did once. I still have to find money around, you know, to compensate. No, kidding. Anyway, of course, you have a team approach. You have people working with you that have experience already in what you do every day, daily. So you have some kind of confidence and the relationship, and you can, of course, agree with the treatment plan that you have to select at the end. But again, what I would like to point out, I believe that is very important. Again, technician is very important, but of course has to be sent to him all the information regarding occlusal plane orientation, vertical dimension, position of the mandible, CR or others, and then inside that position of the upper and the lower. For example, if you talk about the upper teeth, upper and lower teeth anteriorly, and when you increase the vertical dimension, we normally say you increase the vertical dimension of 3 millimeters, 4 millimeters, like a space that you believe that will be perfect to host your new restorations. So the increase of VDO normally is related to the need, how much you need to increase the vertical dimension, because you need to position your new teeth with the ideal length. So normally, as average, as we know, is about 3.5 average between upper and lower. But many times, in order to really have the chance to understand how to increase the VDO, because we did some survey recently, and we asked, for example, many technicians in this survey, and asking them, what you receive for your dentist about the VDO? And the 80% of them say, how much you have to increase the VDO? That's what is the question. And the answer is, un peu, a little bit, un po'. What it means, un po'? Un po' is a little bit is 2 millimeters for me, 2.5 millimeters for you, 3 millimeters for you. So unfortunately, they have not received any kind of information, and they have to decide themselves. And more than that, not 80%, 100% of the dentists normally don't say anything about where to add the VDO, upper or lower. And that makes a big difference, because if you increase the VDO on the lower, you will see, for example, if you increase 1 millimeter of the lower arch, the central incisor, lateral incisor of the lower arch, you will see 1 millimeter longer teeth on the lowers. On the contrary, on the upper jaw, if you have a normal overbite, you will increase the VDO, not elongating the upper teeth anteriorly, but just increasing the lingual concavity of the anterior teeth. That will be added some material, and that will create an increase of VDO. So if you increase 1 millimeter on the lower arch, you will see the teeth on the lower arch longer of 1 millimeter. If you increase the VDO of 1 millimeter of the upper arch, if you have a normal overbite, you don't see any lengthening of the upper teeth. So that's making the difference. So that's the reason why when I try to decide to increase the VDO anteriorly, I start anteriorly increasing the VDO of the lower, increasing the length of the lower until I believe that is okay, it is a normal length. And then all the rest is increasing on the upper teeth, on the palatal concavity. That is not visible until you don't reach the overbite value.
Always getting back just some concept about what we were speaking before. Right now, so aesthetic, occlusion, whatever, and then the team approach, the collaboration. If you have to consider to improve the final result in dentistry nowadays, where do you think there is more room to improve, in the clinical part or in the technical part in worldwide? I mean, where you see the most, where we can improve more from a clinical point of view? So it means for clinician, or do you think that also the technician, we need to, guide them in improving their final restoration? I don't know if you have any experience of working with different technicians or what you see around. What do you think is your opinion about also the quality of the technician?
I believe that it's difficult to say that one role is, one specialty is more important than the other one. Let me give an example about MIPP, minimal invasive prosthetic procedure. Yeah. Is much more delicate for both. For the technician to be precise on very, very thin kind of restorations, but also for the clinician to try to handle the restoration until the bonding procedure will be very complicated, to try the occlusion, to try everything. So I believe that both specialists, being the clinician on one side and the technician on the other side, will be in equal part, really have to be very concentrated and very delicate in order to really fulfill the request of the patient and successfully finalize the case. I don't see one of the two figures that is more important than the other one.
No, that it's more important than the other. My question was if you see that there is, I mean, the need to push a little more with courses on the clinician, just in the way, because you think that the clinician as part of the team are most weak, or the technician?
Maybe clinician. No, maybe more the clinician. My opinion on the clinician. Because again, especially if you are a traditional dentist and you have done for all your life preparation the way you know, old style, to do new things is very, very complicated. It's not easy for the dentist to change completely. At least is my experience with the people following my courses. It seems to be like that.
Yeah.
You know.
Okay. And another question, it's I'm sure that you are treating really demanding patients sometime. And but I think it's an experience that we have nowadays in our office always, to have really demanding patients that are drawn by the images that we can see in the media or so on. So how you can transfer your idea of aesthetic in a really predictable way, and how you can transfer that, I mean, what do you want to do?
Okay, first of all, I believe that when you talk about aesthetic parameters, I try to divide it in subjective and objective parameters. So I try to follow always my idea of objective parameters, like the incisal edge for position, the labial corridors, the interincisal line. All this stuff are something that I believe that is too important not to be, so you cannot avoid to idealize this kind of concept. At the same time, of course, you have also subjective parameters, like for example, the color of the patient. As you know, when you have a patient from, far away, normally in Europe or from Eastern country, for example, it's quite normal to find people that ask you to have white teeth, very, very white, actually. And you can try to convince them that is something that you don't have to do it. Quite recently, a patient said to me, because I was saying, listen, I do as you like, but believe me, that seems really fake. And they say exactly what I wanted, to be fake. And all the people had to see me, that I have the possibility economically to do this kind of work. That is the answer. So that's just to understand that it's completely crazy answer, but it's the reality. So actually, aesthetically speaking, of course, these parameters are subjective parameters, and they pay you. If nothing is nothing against the structure of the restoration, the structure of the abutments, and the function, why not? If you don't impair in any way the function, why should idea to have so white teeth? That is, something that is difficult, but sometimes it happens with the patient to have this kind of problem in selecting colors.
And so, yeah, about the shape, I can imagine that you are always try to transfer your idea of aesthetic with a mock-up or something like this. Are you going to show also the idea to try the color in the mouth of the patient also through the use of the mock-up, or is something that you discuss later at the end?
No, I started, I will finish with mock-up. I want to say something about the mock-up. Today, very fashionable, but I have seen some cases that have done absolutely long time ago, starting from 90s, 92, 93. I did the first example of mock-up because it was absolutely important, especially today. My work today is mainly related to the big rehabilitation case with the MIPP. All these cases, you have lost a lot of volume, length and general volume. At that point, of course, you need to increase the volume. The final volume had to be increased. What is the best solution? Of course, that to send to your technician all the information how to add volume. It means increasing vertical dimension, increase the length, increase the arch width, for example. Altogether, And of course, all these information are suggested to dental technician that they do a kind of mock-up that is only in addition. This kind of mock-up only in addition can create to you the chance to see in preview what we believe that has to be finalized later on. So that's very important because you have the preview. You can start with the mock-up. I normally start with the mock-up. I don't remove the mock-up. I leave until the patient says to me, okay, we're gonna go ahead. Maybe 1 week later. I already planned 1 week later an appointment. So I have all day long. And I start to cut the mock-up back and to take the impressions. So I leave in the mock-up until the end.
Mauro, I was asking, probably you have some slides so to show us some nice case just to explain better this concept and just to evaluate some nice cases, nice restoration.
We can maybe other questions to look in my slides. Let me share with you.
Because I think that it's important sometimes not only to speak about concept, but if you see images, it's much easier to understand.
Yeah, the concept actually was exactly the same, this one. A treatment plan, of course, we started to have the chance to have a systematic approach, of course. That is a traditional tool, is not the difference. But the new trends were, of course, that to have additional volume, because as I explained to you today, my main treatments are that to really create a new kind of final outcome, having the chance to add volume, because most of my patients have worn dentition by attrition, by abrasion, by erosion, by other stuff. And actually, what happened is that they need additional volume. So we have to alter the video, increasing it. We try to have ultralight preparation, and we see now in a YY. And of course, today we can use beautiful ceramic restoration, and of course, hopefully, bonding procedure. So I call this MIPP kind of prosthetic revolution. That was at least my idea. One of the first cases I made is this one. I would like to show you. That's a classic case in which it will be very complicated to really fix the problem, because the patient had a lot of dentin exposed because she has no saliva. The pH is around 5. And that is the result. Unfortunately, they have all the back side without enamel. But if you look carefully, especially on the lower, is more visible. On the interproximal area, you still have some enamel. And if you build up all these abutments before grinding slightly, you can have the chance maybe to save some enamel. Especially enamel was also present on the lingual area, so we extended a little bit on the lingual area, not having a crown design, but like a 3/4 design to find some enamel lingually. We have increased the video. Sometimes he's asked, how much increase? An increase is related to the fact that you can have the chance to really reposition with normal length and normal volume your restorations inside the patient mouth. And actually, this is the increase that we have done in this case is about 3 millimeter, 0.5 or 3 millimeters. So is normally the average of the increase. And of course, my kind of final outcome and my final goal has to be, of course, the maintenance of the structure. That is my goal all the time. How to achieve this result? First of all, increasing the vertical dimension of occlusion. Secondly, reducing the ceramic thickness, and we see in which way. Third, but not last, the enamel preservation in order to have a bonding procedure. So when you increase the video, what to say? If you increase 3 millimeters anteriorly, more or less you increase 1.6 on molars. We are talking about the second molar. We are talking about the worst scenario, because of course, the space on last molars will be reduced more and more. So you increase it 3 millimeter anterior, you increase 1.6 on posteriors. So it will be very complicated also to understand how much you should increase, we said. But again, there is a nice article by Abduo published in 2012, which is stated that whenever indicated permanent increase of the VDO up to 5 millimeter anteriorly is a safe and predictable procedure without detrimental consequences, and the signs and symptoms were self-limiting with a tendency to be solved within a couple of months. Some people were also discussing about what happened in TMJ, but we know by Jeffrey Hawkinson also that the stomatognatic system has the ability to adapt rapidly to moderate change in video. So there is no indication that permanent alteration in video will produce any kind of temporomandibular disorder symptoms. And then Giacomo, look, and myself too, in the group, we had the chance to publish this article among 100 patients, 100 full mouth rehabilitation. Great, because there is so large number, it's never published in the literature. And just to summarize important steps, video increase was average of 3.3 or 3.6 in full teeth support and mixed support. In implants more because we have no reference, of course, at the beginning because they are edentulous patients. But let me say again, 3.5 is the average that we need to increase the video if you look at 3.5 anteriorly between the two central incisors. And also, it was also important to see the adverse event within a couple of weeks. We can have a different kind of problem. The most common is difficulty on speech. We know with the S sound, for example, no? That is very classic. We can have difficulty in chewing, tenderness of masticatory muscles. That could happen. What is interesting, among 100 patients, only 17%, so only 17 in this case, because there were 100 rehabilitation, only 17 were saying something that was not working well. They are complaining about something. It means that 83% were not complaining at all. They come out from the office, even though they were informed about the study that we are doing, they didn't complain about the new video at all. So it's really interesting. So at the beginning, we had the problem with the speech. That is between a couple of weeks. I mean, within 2 weeks, 2 to 8 weeks. But then look, decrease, sorry, it was too fast, decrease, just one person still complain about the speech, and 3 people still having some muscle and joint fatigue. At the beginning, it's quite possible to have it. But the last control, nobody had any problem. That is the reason why we absolutely believe that increasing video can be very possible. You know that many years ago was really impossible to alter video. Today we know that we have a kind of extrusion, intrusion are the same way. It is kind of mechanism that was started to be published by Dahal with the Dahal principle in '85 are quite common today. Many authors show that it is absolutely possible within certain limits, of course, to really play with video. That is important. In terms of reduce kind of thickness of the restoration, I would like to say something about it. Let me go just once.
Mauro, may I ask you something? Just yes. About this topic. Do you think, for example, right now, I know that you try many materials in your life, okay? So you have the experience with the most spread material in prosthodontics, comparing other people for sure. So do you think right now, probably you're using a lot of lithium disilicate, but do you think there is also the opportunity in the future to use a material like zirconia, for example, where we can reduce the thickness of our restoration in more comparing what we can do with the lithium disilicate, or do you think it's an option that we cannot have?
I think the thickness of lithium disilicate can be, of course, absolutely different according to the two structure that still remain there. It means the dentin or enamel. I do differentiation.
Yeah, if we consider, for example, dentin. Okay, so we know that if we go too thin, we can have trouble.
If I have just dentin, I have to redo a case that was already with old crowns. For me, the only option is zirconia. But if you have enamel, I would stay still on lithium disilicate, even though I know that we have increased a lot the capability to, to in some way create a nice kind of inner surface of the zirconia and to be bonded with the monomer phosphate or the cement that are using today. Great. But I still believe that the lithium disilicate gives to me the chance, if you have still enamel present there, that working very, very well. My experience is so good that I really have difficulties to change material when you have enamel. When you have a dentin, I change my foot and I'm using a lot of zirconia too, of course. But if you have enamel, I still prefer to use this kind of material.
But your preference is more related to the, the feature of the material, so the ability to adhere more to the cement, or it's related more, it's related to an aesthetic analysis of the material that why you prefer this?
First of all, because I believe, even though you have shown me also, Francesco showed me very nice result in terms of bonding also with zirconia, with some samples that you did it recently, right? Great, but still, my experience, clinical experience with the on teeth, natural teeth in the patient mouth, tells me that with the enamel that is still there in the tooth structure, with enamel and the etching, the inner surface of the lithium disilicate, to me, create a great sandwich procedure. It means that it is really, really tough. And there are also articles saying that if you compare, for example, zirconia with the lithium disilicate by Petragas, by lithium disilicate that is etched and then bonded enamel, increases 30% more the 400 megapascal that was normally said by the company. So it means that you can increase the bond strength also lithium disilicate over 600, 700 megapascal. So I believe that is something good. And my experience said to me that I really feel very comfortable. We are now, right now almost publishing an article about 38, I don't remember, 40 full mouth rehabilitation with more than 1,000 restorations. And they have incredible numbers. So just 2 or 3, they were fractured over years and years. So the question to do myself is why to change?
No, for example, there are cases where you have, for example, also, I don't know, cases where you have dentin, case where you have, for example, discoloration of the tooth structure and so on. And so
of course, in that case, I use only zirconia. I said to you before, if I keep enamel and the color is quite normal color, I still prefer to use lithium disilicate. If I have the vitalized teeth that are darker, if I are already denting all around, I can use both by right now using zirconia because I want to try more and more, especially the new cubic zirconia with the new aesthetic parameters. Even though I believe that in terms of lightness, if you choose quite a high value, they're both great, but still like more. For my experience, that is more with lithium disilicate than zirconia, I still like more the aesthetic of lithium disilicate than zirconia.
But in case you have, for example, a combination in a rehabilitation of implant or dark teeth or so on, do you change material in the same mouth? So I mean, it's in some area you do zirconia, in other area you combine the restoration with crown or overlay or whatever in lithium disilicate, or you prefer to maintain one material for all the mouth? So
I mean, there are to have one material. I prefer to keep one material in the mouth, of course, selecting different ingots. You can use the MO, HO, LT as you like it, as you know. So HT. So of course, if I use, I don't know, LT A1 or LT BL4 for all mouth, with natural teeth underneath, with natural core underneath, and then have a more discolored teeth, I can play with the layering procedure, with maybe having selected an ingot that is maybe MO or even HO. Even though I never use, frankly speaking, HO. I hate it because it's too dull. But MO is still good, covering quite well. Also, Giacomo did some studies about it. But clinically speaking, I still believe that it's better to have maybe even darker final restoration than a fake one. You know what I mean? When you try to have a more dense, more dull, you see that it's fake. If you see one restoration that is a little bit darker than the other one, you understand that it's darker underneath, but still seems more a natural teeth. Understand what I mean?
No, yeah, that's great. Yeah, it's true. No, getting back to the zirconia, I think it's about the adhesion. I think that I try many different cement, many different approaches, and what I think it's really important is to follow the precise steps so to avoid any contamination of the zirconia surface. And in my test, I saw that the adhesion was super great also on the zirconia. What is really important is also to have really to use, for example, in the cement, to use the proper mix pack, so the proper tip in the way to mix the cement in the proper way, just in the way to have the perfect material. Because if we don't use, for example, this type of original stuff, sometimes the cement is not really mixing in the proper way, and you can have, or if you mix by hand, you can have trouble later in the final result of the material. This is one for sure. But as cementation right now, I don't see any trouble in cementing also with this kind of procedure, also the zirconia. Right now, yeah, just to finalize, we have 10 more minutes. So if we want to see some nice picture, and then I would like to ask you, we heard that you are launching also a new book, and then we are curious to know what is going to show, what you are going to show us in this book as well.
Try to understand what will be the next book. Will be MIPP.
That's great.
MIPP. That is the topic. I believe that is my topic right now, because I believe that is great result that you can achieve. And again, the experience with the many rehabilitation I made already tells me that I can really play with that in a perfect way right now. I really enjoy doing it. It's quite tough work, as you understand, as you know, actually, because you do also a lot of this kind of rehabilitation, but it's still I feel very comfortable, because beginning after is fantastic, actually. Giacomo too is doing a lot of this, and we know that is really very satisfactory result at the end. Just to point out this kind of picture, you know, here, the same company that produced the lithium disilicate put now the thickness, minimal thickness is 1 millimeter. And you know what? The same company said until yesterday that was 1.5 the minimum. I was the one that 10 years ago, more than 10 years ago, was starting to use 0.8, because of course you have to consider that it's very important. Let me show you this. Look, you increase the video. That is an example. 2 molars, now they are separated because we have increased 3 millimeter anteriorly. So we have 1.6 as average, of course, on posteriors, on the last 2 molars, okay? So means an average of 0. I'm showing you right now. Yes, you see my picture?
Yeah, we see you.
Yes, okay. So you have here 1.6 millimeter. Now, increase the video gets you the possibility to have this kind of space. Now, when you prepare 1.5, when you believe that you have to have 1.5 millimeter of thickness of the ceramic, better to say, you will destroy your teeth underneath. You never start with a virgin tooth like this, as you know. You start maybe with some enamel still present, and if this is the situation, you can say that in this case, if you increase the video and you're still working on traditional way, you can have the chance to cut anyway the tooth, because you need 3 millimeters of this space to host these 2 restorations. But if you have increased 1.5, 1.6 on posteriors, that means 3 millimeters anteriorly, you can find automatically 0.8 per arch. It means this hypothetical preparation is not made because you have already this space thanks to the increase of video. The video increase gives to you, allow you to have 1.6 at this point. If you keep the thickness of your restoration only to 0.8, you succeed. It means that if you have still some enamel there, you can keep it 100%. And that is something incredible, because you at this point, reducing the thickness, you have untouched enamel. And you can just refine the restoration as you like. So we know that anteriorly, then you can layer. We normally do this kind of differentiation. We go to the posterior. According to the enamel presence, you can get from 0.5 to 0.8. If you have not incredible amount of enamel, just 50%, you prepare 0.8. If you have enamel everywhere, or almost complete enamel, you get down to 0.5. So then you reduce the ceramic thickness, as we said. It was 1.5, as you could see from this picture. Now is 1 millimeter, much better. So at this point, you can, of course, bond your restoration, because if you keep enamel, you can bond it. You can keep enamel 100%. And I would like to show that was the preparation I made in 88. That's the preparation I made in 2008. I put composite everywhere. I kept enamel in also the lingual part. I have some little chamfer on enamel, and I have the chance to bond it at this point. We create a kind of full veneer. It means that on the back side you do veneer. On the lingual part, because you have to add volume, because you have increased the video, you have a space between the lingual concavity and the opposing dentition. So you have to increase the balcony of the lingual part, creating this full veneer. So it's an extended veneer. It's a design of the crown, but it's not a crown. The crown is when you prepare the teeth completely, 1.5 like a shoulder. That is a full veneer. It's an extended veneer that is needed because you increase the video to cover the space between the upper and the lower anterior teeth. 28 restoration.
May I ask you just a question, just because
sure.
Sometimes there is also the approach, this is the full veneer. Sometimes, just the last question, because almost we finish our time, but do you consider acceptable in the anterior part to do the V veneer, so in the way to maintain the contact points of the natural teeth, or in some cases, or do you prefer to go rounded and then prepare and also the contact point create the new ones?
Okay, actually, depending of course on the contact point, what happened there. It means you have interproximal area with all the composite, for example, or more than that. Sure. On anteriors, for example, on anteriors. If you like the disposition and of your teeth, you don't want to change anything, you can keep having the V veneer. It means that you keep the interproximal area. You do buccal and lingual surface without touching the interproximal area. Just to explain from people that maybe don't know exactly what it means for V veneer. But at the same time, I would say if you want to maybe highlight the central incisor, create more dominance incisor, if you cut in the middle interproximally, keeping enamel, I don't see any difference. If you keep enamel 100%, even cutting interproximally, you are not more aggressive because you kept enamel. You are enamel 100%. So in this way, you have the freedom to change the disposition and the size of the teeth. If you keep the interproximal area, you have no this possibility. Understand
Mauro,
what I mean?
Great. Mauro,
yes.
Beautiful, beautiful, of course, work, and we're just gonna have to refer our audience to the different classes we have on prosthetics. I just want to finish maybe one question to connect your prosthetic work to also digital. Can you give us your feedback a little bit on digital dentistry? Yes. So are you scanning with a digital scan, or are you still doing analog or traditional? Are you using digital smile design? What is your your workflow in your practice?
Okay, thank you for the question. I'll be happy to answer. In the meantime, I would like just to go ahead for the last 4 slides, because I would like to show you what happens into this case. That was a complicated case, as you understood, because of course it was very delicate. You can have decays everywhere. Maybe he doesn't remember at all. But my friend Dennis Tarno, when I present this case in Cancun, say, Mauro did a great job, but be careful about decays. It's true. It's true. But I want to show you, up 11 years, what happened. You see the X-rays, we had the chance to maintain vitality of 28 teeth. No one was vitalized. I remember the condition, the initial condition. But of course, you never know what happened next. That was the time of delivery. Everything beautiful, great. We have the exclusion of posterior teeth with the anterior guidance. We have improved the aesthetic result. But that is delivery, that is 11 years after. And that is something that I like to show, because this patient was absolutely very complicated to keep it, to maintain this case over years. We have upper occlusal and the lowers. And you see that was also the comparison between before and after, time of delivery, 11 years after. Still there, everything there, completely there, the upper and the lower. So just to explain to you that, of course, this is a really nice technique that you can really achieve, and even in very complicated case like this, in which in a couple of years you could have some more decays, you still have the chance to have all the teeth vital, new x-rays 11 years after. That is the best picture I can show you. Talking about digital, you know what, getting older for me is more complicated than other people to stay in digital 100%. In my team, I have people that are dedicated to digital, and both of them, especially Francesco, but also Giacomo, they are great in digital too. Younger people are more adapted, you know, they're easy to adapt to this kind of solution. What I believe that is more important, you mentioned, for example, like digital smile design to have the chance to preview in the screen the final outcome and to do the show to your patient, like having a PlayStation on the evening with your babies. I would like to say that we have done a digital way to build up an application. And also Francesco and Giacomo were also involved in this project at the beginning, in order to really create for the dentist, the dental technician, for the orthodontist, for the implantologist, the way how to decide through all the steps on the aesthetic and functional parameters to determine where the position of the teeth should be. Not in the incredible way to show on the screen all the 6 anteriors without any kind of occlusion on the lower arch. Lower arch don't exist in all these systems, in all these kind of digital smile design. Normally they don't care about the lowers, about the posteriors. It seems that just the 6 upper anterior exists, that's all. In our case, we put together all the potential steps of aesthetic and functional parameters in order to really create this kind of final road that is absolutely with the great content inside. Is a road that have inside the great content. Of course, it's not so easy going like the other system that can just do a show without having any kind of real information in how to really position the new rehabilitation in the space. So that is my answer about digital. Of course, digital, we use the intraoral scanner right now, of course, yes, but I still don't use for full art. So we have the intraoral scanner, we use it, but we don't use it for full art. And of course, we are trying to improve. In our team today, we have Leonardo Baccarini that is absolutely very capable to work on digital very, very well. And so I am improving as a team, as Fradeani education team. But myself, a little bit more in the back, but what I was really proud to have together with other people, also to Francesco and Giacomo, develop this kind of system of app that is really something completely different in terms of content, very full of content.
Thank you. Mauro, it was a really great explanation. And then I remember such an effort we put together in the way to obtain the GetUp application. And then I think it's really well created and with a clear idea. It's not something only about aesthetic, but it's also functional. So with this, I want to thank you, Mauro, for the great interview, your time and whatever. I want to thank Giacomo to be with us, and I want to thank also Sasha for this kind of nice invitation and whatever. So if you want to conclude, Sasha, with some words.
Yes, please. So Francesco, first of all, thank you for hosting the interview. This was, I think, a very, very special interview because we have really like a team together of really specialists in prosthodontics. I would say Mauro is like the father of this minimal invasive prosthodontic approach, and you can learn so much from that. And of course, Giacomo and Francesco are, you know, kind of part of that from the beginning. And there was the student-mentor relationship between Francesco and Mauro and Giacomo. But now you can see everybody has become an expert themselves. I also want to say that Mauro and I have been working together for more than 20 years. Yeah, unfortunately, we have, you know, we've been in 2 different continents, but we've had the pleasure of, I know, at least 2 fantastic cases, one single tooth case and one multiple tooth case, which, if you want to see that, it's in the textbook from Mauro Fradeani. And that one, Mauro, you just told me, is now over 20 years stable, functionally and aesthetically.
Yes, that's true. That's true. I still remember, Sasha, when we are together in Vancouver. No, maybe it was close to Vancouver. And after my presentation, you said to me, Mauro, you have to do a case together. I just came back home and I met the actually the father of this guy, of Tommaso, asked me, please have to take care about my son. So I immediately called back to Sasha. I found a case for you guys. So come back.
Excellent. So,
thank you, Sasha, for the opportunity to give me the chance to talk to you guys.
Yes, and for everybody, please know that Dr. Fradeani has a very active institute in Italy, and of course, everything that he's teaching you here in a very short period of time, he can teach you in his courses really very, very good. So I refer you to his institute. Then, from our guide side, remember that we have our online master classes, which are all surgical and non-surgical. So please go there. With the membership of Guide, you have the full access. And we have a big pleasure there as well, because we have a prosthetic online masterclass from Dr. Fradeani and, not Dr. Fradeani, sorry, Dr. Francesco and Giacomo. And you can see it's like the topic is very interesting, because we have over 326 dentists who are learning online in this masterclass. So this will be online as an available to all the members that we have. Then I want to thank also our virtual sponsors. And for those of you who cannot wait for the new book from Dr. Fradeani, his current book, of course, is available, and I have it for many years. The case that we did together is inside, and I think it's really like a Bible for modern prosthodontics, so I can refer to that. And then we also have a new virtual sponsor, Salzer, which has very interesting products, which really, again, make it possible to have this high quality work which you're doing in your practice. So I want to thank everybody. Enjoy the rest of the day. Buonanotte to the Italians. And Mauro, grande, as always.
Thanks a lot. Ciao.
Ciao.
Ciao. Ciao.
Ciao
a tutti.
Ciao Francesco. Ciao Giacomo.
Ciao Sasha. Ciao Mauro. Ciao Francesco.
Ciao ragazzi.